I'll now request Dr. Hemlata. She is, as I told you, she is with Center for Sight and a very proficient, efficient surgeon for cataract. She'll be talking about the third hand, that is the pars plana approach, the instrumentations for a cataract surgeon that you need to manage cases with zonular dialysis or vitreous coming forward, etc. Over to Dr. Hemlata.
A very good afternoon to all of you, and my sincere thanks to Dr. Mahipal sir for giving me this platform to talk about this less practiced but very useful technique, that is pars plana approach for the anterior segment surgeons. So what are the situations that can be handled in a more efficient way via pars plana? When there is a large capsular rent with large cortical matter remaining behind, especially when the surgeon has already placed the IOL in the ciliary sulcus. Then there's phacomorphic glaucoma where the pressures are high despite IV mannitol, or where the IV mannitol is contraindicated because of systemic comorbidities. Then we get shallow AC and hence inadequate working space. In cases of zonular dialysis or weakness causing acute intraoperative fluid misdirection syndrome, subluxated cataracts where there is repeated vitreous prolapse through the area of zonular dialysis, and then dense corneal opacities where the conventional microscopic illumination does not work well. So I'll be showing all these interesting cases, but let's first see about the instrumentation.
23-gauge micro-incision trocar cannula system forms the backbone of this instruction course. It is imperative to understand its component and usage to fully utilize the tricks shown in the subsequent videos. A typical non-valved trocar cannula set consists of 3 23-gauge trocar cannulas, an infusion pipe, and 3 scleral plugs. Trocar cannula consists of a sharp spear-shaped trocar threaded over which is a round-bodied cannula. In a phakic eye, the cannulas are inserted 4 mm from the limbus. The conjunctiva is retracted slightly, and the trocar cannula is inserted in a 2-step fashion, initially going parallel to the limbus for half its length and then going perpendicular to enter the sclera. The infusion is secured in the infratemporal cannula. And the superior ports used for vitrectomy cutter are plugged till further use. It is a relatively simple technique which can be mastered easily with little practice.
And let's see some interesting cases. This first one is a young patient with traumatic intumescent cataract. Now, as Dr. Vasavara has clearly shown that if there is a large PCR with vitreous prolapse, if you cut the vitreous from behind, it retracts back and without any extension of the PCR. But if there is vitreous prolapse and we are doing anterior vitrectomy, there is more prolapse of the hydrated vitreous that can lead to the extension of the PCR. So keeping this in mind, we manage this case of traumatic intumescent in cataract with both anterior and posterior capsule rupture. So there was a large capsular rupture, so I'm trying to remove whatever loose lens matter is there. Most of it is intermixed with the vitreous. So without causing any traction to the retina, just the loose lens matter is removed, and then we proceed with the pars plana vitrectomy. So as shown in the previous video, just entered via trocar, and we do the vitrectomy using a vitrectomy cutter. Now you can see that the cutter is parallel to the iris, so it's very easy to move it freely in all directions. First we do the vitrectomy, clear the vitreous, and then switch to the aspiration mode. So now the thing is that in this way you can switch between vitrectomy and aspiration modes just by changing the foot switch position. You need not remove the cutter again and again. and we clear the area of the vitreous, then switch to the aspiration mode and slowly remove the loose prolapsed vitreous and the cortical matter. In this way, there is no traction on the retina, no extension of the PCR, and we are able to remove the vitreous and the cortical matter without damaging the posterior or anterior capsule. You can see even the last bit of the cortical fiber can be removed safely. And after the complete removal of the vitreous as well as the prolapsed vitreous as well as the cortical matter, the 3-piece intraocular lens could be safely placed inside the ciliary sulcus. Here is another case. This one was a lady of 86-year-old lady with phacomorphic glaucoma, and the pressures were not coming down with IV mannitol. So here again we decided to go via pars plana. The trocar is placed, and since it's a blind procedure, we are just removing the vitreous that is coming out of the trocar. This little bit of removal of the vitreous will deepen the AC instantly and lower the intraocular pressure and give us adequate space to maneuver the capsular axis. Now, most of these patients, they have areas of zonular weakness in the periphery. So when we are using the fluid and doing the phacoemulsification, the fluid might misdirect posteriorly, causing acute fluid misdirection syndrome. And sometimes in between the surgery, you get high pressures and iris prolapse, like happened in this case. You can see that the iris is prolapsing through the wound, and again the pressures are high. So we need not do anything. Again, remove the plug, remove whatever extra fluid is there, and again it's going to instantly lower the pressure, deepen the AC, and rest of the procedure can be completed safely. So we are able to implant IOL, single piece IOL inside the capsular bag, and in the end you just pull out the trocar and it leaves a self-sealing wound. There is no need of any suture application. This is a case where the patient had traumatic subluxated cataract for more than 180 degrees. So here, when I injected the viscoelastic, there was prolapse of vitreous. So again, we are entering via pars plana, and a limited dry vitrectomy is being done. Triamcinolone is used so that we are able to see the tip of the cutter throughout the surgery to avoid any accidental damage to the posterior capsule. Just a limited dry vitrectomy is done because if there is excessive vitrectomy, that will cause undue movement of the capsular bag, leading to extension of the zonular dialysis, and will further deepen the AC, causing the surgical steps, making the surgical steps more difficult. So once the capsular tension ring is secured in the bag, phacoemulsification is not a problem because already the femto pre-fragmentation has been done. So this is not a very hard cataract, so the emulsification was not a problem. And throughout the surgery, we got sufficiently deep AC without repeated vitreous prolapse. You can see that how shaky the bag is, and once the epinucleus is removed, removal of the cortical matter is a little difficult because of the placement of the CTR. After complete removal of the epinucleus and cortical matter, we are placing the capsular bag, this intraocular lens, 3-piece intraocular lens inside the capsular bag, and a little more vitrectomy is done to remove the prolapsed vitreous from the area of zonular dialysis. So this is the post-op outcome, very well-centered lens. So Dr. Shreyas will be speaking in detail. I'll just show a very quick short video. Now doing phacoemulsification via conventional microscope is very difficult in these dense opacities. So when chandelier is used, the light falls on the retina and gets reflected back, giving us a very good red glow against which the capsular axis can be done very safely. And also we get a very good depth perception, so chopping is not a problem. And all these steps can be performed under direct visualization without damaging the posterior capsule. So we remove the cortical matter and place the single piece lens inside the capsular bag and pull the trocar, leaving a self-sealing wound behind. So you can see that all these situations could be managed successfully via pars plana. Thank you so much for the patient listening.
Wonderful videos, madam, as always. And just one quick question. In that eye with the phacomorphic glaucoma or even intermittent cataracts where you're using the pars plana to decompress the vitreous, is there any IOP cutoff that you use? Is there any ACD cutoff, anterior depth cutoff that you use where you decide whether to just go ahead with phaco or whether to do the pars plana?
See, if the pressures are down with mannitol, we need not go via pars plana. But if despite IV mannitol the pressures are high, then we have to decompress before entering because it can lead to even choroidal bleeds also.
And do you do, is there some vitrectomy also being done by the retina surgeon or only tapping?
Only just
whatever
the limited dry vitrectomy. We are not entering inside the vitreous cavity. It's just whatever vitreous comes out, egresses through the trocar, that is removed, and that is sufficient.
I think this concept is very much catching on. A lot of surgeons, especially glaucoma surgeons with high IOP preoperatively, are using this decompressive vitrectomy option to reduce and makes the eye a little softer and easier surgery.
We are able to avoid so many complications.